Today's topic is nursing ethics and legal responsibilities. It's very dry, but very, very, very important information. Knowing what your responsibilities are ethically and legally is going to protect you, protect your license, and protect your patients. So let's get right into it. Um, Care and safety of clients or patients, I prefer to call them patients, is complex and it's all tied to legal and ethical aspects. The Nurse Practice Act guides nurses in making judgments to impact the health and well-being of our patients. Code of Ethics for Nurses says that all nurses, including RNs, LPNs, and students, must adhere to this code of ethics, upholding the ideals, duties, and obligations of it. The International Council of Nurses Code forms the basis for the national codes, and it addresses patients, practice, responsibilities, global health, and then it includes equity, social justice, climate change, technology, and sustainable development goals. The ANA Fundamental Values Provisions 1 through 3 include providing compassionate care and respect to every client, recognizing their own unique worth and dignity, acting as an advocate for all patient rights and needs, promoting and protecting their health and safety, and then that the nurse's primary commitment is to the patient, whether it's the individual, a family, a group, a community, or a population, depending on the kind of nursing that you go into. Professional duty is provisions 4 to 6. You should demonstrate authority. Accountability is the big one here, and responsibility for promoting best practice. You want to promote health, provide care as best as you can, and maintain your competence. That's why we're required to do continuing education units for every license renewal. And you want to maintain a healthy and safe practice environment and be as ethical as possible. Advancing the profession, we want to do research, we want to ask questions, and we want to make scholarly contributions. We want to participate in developing these practice standards and policies. We want to collaborate with the interprofessional team to protect our patients, decrease health disparities, and promote integrity of the nursing profession. So, the foundational ethical principles are autonomy. That's respecting the patient's right to make their own decisions. We are not going to force things on them. They have every right to say no. And it's our job to discuss with them why it's important that they don't say no, but we need to respect it if they do and just document. Beneficence is the obligation to do good and do what's best for our patient. We're not going to do things that are harmful for them. Non-maleficence, or malfeasance, excuse me, the duty to do no harm. If a doctor writes an order and you feel it will harm the patient, it is your ethical duty to refuse to follow that order. I have done it myself. I had a physician who wrote an order for me to give a heparin drip to a patient who had an active bleed. He was concerned about her atrial fibrillation leading to blood clots. I was more concerned about giving a blood thinner to somebody who was bleeding out. He tried to call me insubordinate, and it is very important that we remember we are not the physician's subordinate. We are their colleague, and we do not have to do everything the physician says. If an order is unsafe, it is our ethical duty to not do it. I did not get in trouble for that because my patient's safety was paramount. If you get in trouble for doing what is right for your patient, you have every right to go above the person who yells at you and get them in trouble because patient safety is the most important and paramount thing. Veracity. We are going to be honest with all of our patients. We are not going to tell patients everything is going to be okay if we are not 100% sure everything is going to be okay. We owe it to them to tell them the truth. If we don't know the answer, it is okay to say, I'm not sure, but I will find out for you. That is much better than pretending to know something you don't. Fidelity, that loyalty. We're going to keep promises to patients. We're not going to say, I'll come back and chat with you later if we have no intention to come back and chat later. We can tell patients that we don't have the time to chat. It's understandable. Nurses are very, very busy, but we're not going to lie to the patient and tell them that we're going to. And then justice. We want impartial, fair, and equitable treatment, not equal. Equitable and equal mean two different things. Equitable is fair, equal is the same. Take it as you have two children standing in front of you, and one needs a band aid and the other needs an ice pack. Equitable care is giving one child a band aid and one child an ice pack. Equal care is giving both children a band aid. So it's important that we provide the patient with what they need, and we want to allocate resources appropriately. This is where a lot of DEI comes in. This is where we're focusing on those social determinants of health to make sure we are giving equitable care regardless of ability to pay, religion, race, creed, all of those kind of things. We want to make sure everybody is getting the care they need regardless of anything out of their control. Autonomy and beneficence. Autonomy means just they can refuse care, even if you think they shouldn't, even if the family thinks they shouldn't. For example, I believe that a person who is hemorrhaging and young and has young children should accept blood transfusions. That is my personal belief. However, a Jehovah's Witness likely is not going to accept that transfusion regardless of what it means because it is against their religious belief. I have to, despite my very strong belief that that child needs their mother, allow that patient to make that decision. And it's a very hard thing to wrap your mind around because it feels like you're doing the wrong thing, but the patient has the right to choose. And then we're going to actively try to benefit the patient. So we're going to comfort them. We're going to put up the fall precautions. We're going to do everything we can to minimize the harm to that patient. If they're hemorrhaging, we're going to try to stop it. We're going to give them fluids. We're going to give them a medication called erythropoietin that's going to help produce red blood cells. They will accept that, but they cannot accept blood products. So we're going to do everything we can to allow them to make their own decisions and still try to keep them safe. Non-malfeasance. That is do not do harm. If something can negatively impact the patient, we are not going to do it. Veracity. Telling patients, hey, I made a mistake. It's okay to make mistakes. Any nurse who says they've not made a mistake is lying or very, very lucky. It's not important to not make mistakes. It's important to own your mistakes, learn from your mistakes, and report them to the appropriate people. Fidelity and justice. Keep your promises. If you say you're going to call the doctor, call the doctor. If you say you're going to bring a patient a foot brace when you can get an order, get the order and get the foot brace, or go back and tell the patient, hey, I wasn't able to do that. We're going to keep our promises. And then ensuring that fair treatment and resource allocation. And we're going to determine who needs it most urgently if we don't have equitable resources. In an instance where there's 10 people who need help and there's 2 people to help them, you cannot save everybody. So that's when you need to allocate those resources appropriately. And it's a very difficult thing to do, but the ethical principles will always guide you. Personal values and professional values can be the same, but they may be different. And it's really important that we identify our own values so that we can navigate if there's a conflict with what a patient believes. If you are very adamantly pro-life and you're working in an OBGYN and a patient comes in asking for an abortion, it is not okay to say, no, you cannot have that abortion because it's what I don't believe in. But it is perfectly okay to recuse yourself from that case because it's not something you believe in doing. So we need to understand our own biases and our own values in order to provide good care. Altruism. That is just putting other people's needs first. That's It's time for me to go to lunch, but Mrs. Jones was due for her pain medication 10 minutes ago, so I'm going to go give her that pain medication before I go to lunch, or I'm going to make sure that somebody else is prepared to give that medication. Human dignity, respecting that people are human, regardless of what they choose. One thing that's very difficult is if you work in emergency or you work in corrections medicine, is looking at someone who's done something absolutely horrifying and giving them that human dignity. It's very important that we put aside our personal beliefs when we're taking care of our patients. Integrity, that honesty, upholding the professional standards even when it's difficult. I was taking care of a man who assaulted a 12-year-old girl. It was very, very, very difficult to uphold those professional standards and give him good quality care without giving him a piece of my mind. But ethically and professionally, it's what I needed to do. He didn't get sweet, kind, soft person. He got cared for and he got good care, but he didn't get the above and beyond kindness. And that is okay, but you cannot be mean. You just deliver quality care impartially. Autonomy, again, letting them make their own decisions. If a 90-year-old wants to be full code and that is her decision, not influenced by anybody else, that's what we're going to do. But if that 90-year-old wants to be a DNR and the family is against it, we're going to do everything we can to protect that patient's autonomy. And then social justice. Everyone in the world has a right to their health and well being, and it's important that we as nurses recognize that. Approaching ethical dilemmas is very, very difficult. It's when your ethics and values disagree with the patient's, or there's no clear right or wrong solution. So it's important that we collaborate with our colleagues to help make those decisions. Every hospital system has an ethics team. When we look at Terri Schiavo, she was a woman who was declared brain dead, and her family wanted to keep her on life support because they held out hope that Terri would return. Terri's husband, or significant other, I don't think he was her husband yet, wanted to remove life support. That was a major ethical dilemma that had to be brought in front of courts and ethics teams. That was not a decision that could be made by one person alone. So, with those kinds of things, it's okay to admit you're in over your head and ask for help. So, the decision making framework is designed to help you with those decisions. We want to look at what the dilemma is. Is it a true dilemma, or is it just something that the patient and their significant other are disagreeing on? And we want to look at who is most affected by the decision. Then we want to look at solutions and apply those ethical principles. We want to look at all of the possible solutions and assess using the ethical principles. Then we want to include all relevant people. We want to look at the legal ramifications of the decision. We want to look at our policies in the hospital and then collaboratively decide on a solution. No one person should be making these decisions. Then we want to review, reevaluate the situation before we do anything, and then look to see if it was effective. Common issues for nurses: stem cell research, late term pregnancy terminations where the fetus or the mother would not survive, medical assisted suicide. Refusing or terminating treatment can be a very difficult ethical issue for a nurse because they may believe that if the patient tries just one more chemotherapy, it might work, but the patient doesn't want to. Patients with substance abuse orders are those who have experienced or committed abuses. Patients in legal custody, allocating scarce resources like in a mass casualty incident. It's very ethically challenging to determine which patients get the care when there's 10 or 13 who need that care. When you're around um, unethical practices, like in clinical, I've had students bring up a lot of unethical practices to me, and that can be really a big dilemma for a student because they feel like they are powerless. And then that hesitancy to talk to your peer or superior about their ethical um, issues or their unethical practices. There are legal acts that protect patients. EMTALA is the Emergency Medical Treatment and Labor Act. That means that if you go to an emergency room, you cannot be turned away regardless of your insurance or ability to pay. HIPAA protects your private health information. Maintaining confidentiality is essential. It is not just an ethical principle, but it is also a legal principle. So we are not going to post anything identifiable about a patient on social media. Best practice is do not say anything on social media about your clinical day, your work day, or your patients. Not a thing. If you post anything, there is always a possibility somebody can find out who you're talking about. And we will never be posting pictures of clinical sites, work sites, or patients. We're going to maintain those professional boundaries. If a patient messages you on social media, you need to remain professional. If you know someone outside of the hospital setting or as a patient, for example, I was taking care of a woman and I ended up unknowingly going on a date with her nephew. It was an ethical dilemma. And I went to my boss and said, "This is what happened. What should I do?" I was allowed to maintain my friendship, but no information could be given by me to him without the express written consent of his aunt because of that friendship. So it is okay if you organically, outside of the medical setting, become friends with a patient. If 2 years from now you run into a lady that you took care of in the grocery store and she invites you over for tea, that is completely different than if you develop a friendship with the person that's laying in the bed and you're caring for them. Any posted information can potentially be viewed by patients, your peers, and your supervisors. So make sure we are keeping all patient identification secret. We're not sharing any information about patients, and best practice is to never share locations of jobs or clinical sites whatsoever. Um, Privacy settings, keep your personal and professional information separate. Don't put where you work on your personal Facebook because if you put where you work on your personal Facebook and you say something that can be perceived as a negative, your employer can let you go because that can reflect poorly on them. We're going to advocate for patient rights. We're going to report all those violations of legal and ethical standards. If we see something on social media, we're going to report it. And we're going to work with our employers to develop policies to protect our patients. Genetic testing is a really ethical and legal can of worms. There are acts like the GINA Act that protect patients from having their genetic information used against them to increase their insurance premiums. But it's really important that if we are working with a patient and we know genetic results, we are not sharing that information with anybody other than the patient. So, criminal and civil law both handle different parts of nursing. With criminal law, guilt has to be proven beyond a reasonable doubt, and you can get punished. Civil law is disputes between individuals or organizations. These are your malpractice, your negligence. You're going to be remedying the harm, settling claims, and that's where a lot of financial penalties are put in. Tort law. Acts or omissions causing recognizable harm to a person or their property. It includes malpractice, which is failure to meet standards, and negligence, which is breach of duty, and any intentional torts like assault or battery. Assault is saying, if you don't stop, I'm going to hit you. Battery is hitting. Patient consent. Informed consent, we have to give them detailed information, risks, benefits, alternatives. Generally, if it's surgical, that is coming from the doctor. We should not be expected to explain a surgery to a patient. If a surgeon comes to you and says, "Can you tell him what's going to happen when we do this surgery?" you are to say, "No, I cannot legally do that. You need to do that." We can reinforce education, and we can tell the provider the patient didn't understand and that they need to go back. Implied consent is when somebody is unconscious, it is implied that we can take care of them. If you say, I'm going to take your blood pressure, and a patient holds out their arm, that is implied consent. Advanced directives, that's going to be your living will, your durable power of attorney, your um, your healthcare proxies, your DNRs, all that kind of stuff are legal documents that say what the patient wants if they're incapacitated. It is important that we educate patients when they get those DNR orders to take that pink sheet of paper and put it on their refrigerator when they get home, because that is the first place EMS looks. Good Samaritan laws protect you only if you have no duty to act. If you're walking down the street and somebody goes right down in front of you and you perform CPR and you break their ribs, they will not be compensated if you break their ribs. They're not going to be able to sue you for compensation because you are protected by those Good Samaritan laws. So this is one of the most difficult places that nurses and nursing students especially have, is protecting the patients and reporting anything they see that is abnormal. I can say that legally you cannot be retaliated against. So if you report something illegal or unethical, you are protected legally. They cannot come back and say, you reported this, you're fired. There's also mandated reporting. These are suspected physical, emotional, sexual, or financial mistreatment of vulnerable individuals, specifically the elderly, those who are developmentally or cognitively impaired, and children. Mandatory reporting of diseases. We have to report specific diseases: anthrax, HIV, chlamydia, gonorrhea, syphilis. These are all diseases that have to be reported to public health so we can track them and prevent them from getting to be a big outbreak. Incident reporting is a way that hospitals are using in order to learn from the incidents. So, what hospitals are considered now is a just culture, which is when you make a mistake and you report it, the system is going to look at it from a systems issue. Where did the system go wrong, and how can we make it not happen again? Issues that you report should not be penalized. It should be, we provide you support, we understand people make mistakes, and we're going to do what we can to avoid those from happening again. This is not to say that if you go against everything you are taught in nursing school, you are protected. When it comes down to it, nurses like RaDonda Vaught, who went in and bypassed every single right of medication administration and ended up with a woman losing her life because she did not do everything she was supposed to do. This is not what just culture applies to. Just culture applies to, you did everything the way you were supposed to and you made a mistake. So we're going to do incident reporting. We're going to document anything unusual, meta errors, patient falls, any near misses. If something happens and you're about to give vancomycin to somebody who's allergic to it and you scan it and you go, oh crap, wrong patient, we're going to document and record that because they need to look into how that happened in the first place. So we're going to try to improve our processes without punishment. Sentinel events are things that result in permanent disability, temporary injury, or death. They need to be investigated immediately so that we can determine what happened and how to fix it. And then, like I said, a just culture is where accountability is maintained and we want to learn from mistakes and support those who make mistakes. Mistakes are okay, negligence is not. Client abandonment. If you accept report on a patient, you cannot then leave. If you leave, you will have abandoned that patient. If you walk in and you go, this is an unsafe assignment, it is your duty to not accept report. Staffing ratios. It's important to make sure that you have a ratio that is doable. Unfortunately, in New York State, there are no legal staffing ratios. The only state with legal staffing ratios is California. And unfortunately, without these legal ratios, it's up to nursing and administration of individual hospitals to determine what they consider safe. And delegation. We are delegating only tasks that can be delegated. We cannot delegate tasks like initial education, assessment, evaluation to unlicensed personnel. LPNs are a little bit different because they can gather data, report it back to the RN, and they can reinforce teaching. CNAs in the NCLEX hospital and overall should be only doing tasks. They should be doing things like ambulating the stable patient that's been evaluated by the RN, giving baths, doing perineal care, monitoring intake and output, just writing it down. Those are tasks that CNAs can perform. We are not delegating teaching. We are not delegating medication administration. We are not handing a patient a cup of medication and telling the student or the CNA to just make sure they take them. It is the responsibility of the person giving the medication to monitor the patient taking. So, safe delegation, we have 5 rights. We have the right task. Is it within their job description and facility policy? Some facilities allow CNAs to do phlebotomy. Some don't. We need to know our individual facilities' policies. Is it the right circumstance? Is the patient stable? And is the person trained to report changes? Is it the right person? Do they have the knowledge and the ability to perform the task you're asking them to do? Have they been trained? Did you communicate right? Did you give specific instructions? And did they ask any questions if they didn't understand? And then are you supervising them? Any task you delegate, you are still responsible for evaluating the outcome, making sure it's documented, and making sure it's done. Breaches in nursing practice, failure to maintain standards of care. You're not adhering to what you're supposed to do. This can lead to negative outcomes and be considered professional misconduct. Lack of confidentiality. Violating HIPAA can lead to jail time, license loss, and fines. Falsifying health records. Are you documenting incomplete information? I don't know how many times I've followed a nurse where we've had a patient who is missing a leg who has documented bilateral pedal pulses. Do not do this. Do not just say the patient has 16 respirations because it's easier than counting. We want to make sure that all of our data is accurate and complete. Anything that is inaccurate or incomplete can compromise patient safety and you can lose your license. Your license is not protected because other people do it. We're watching fatigue. Is the nurse physically exhausted? Is it impairing their ability to perform safely? Longer shifts and heavy workloads lead to more errors. And then substance abuse disorders. A lot of states have resorted to doing rehabilitation for nurses with substance abuse disorders because it is so pervasive in the field because of the ability to access the medications easily and the amount of significant stress that nurses are put under. So, impaired nurses do pose dangers to patients. But instead of penalizing and taking away nurses' licenses for doing substances when it's so pervasive, we would have no nurses. So instead, we're doing rehabilitation programs. We're helping nurses get clean. We're helping them maintain sobriety. And we're helping them maintain their license. A lot of the time, nurses will be put to work in places that don't have access to narcotics. They'll still be drug tested constantly. Any suspicion of drug abuse or diversion can lead to being in a rehabilitation program. So it's important that we maintain it and we report if we think somebody is impaired. So ethical nursing is just maintaining the patient's safety above everything, maintaining their autonomy, their ability to make decisions, and making sure that they are always safe. We're reporting maltreatment if we see it. We're reporting certain diseases if we see them. And we're doing incident reports if something goes wrong.